Next outstanding speaker, Dr. James Armitage, who is a Joe Shapiro Professor of Medicine at the University of Nebraska Medical Center. He has served in numerous administrative positions, just as past president of ASCO and the ABMTR, as well as in many national and international oncology committees. He has published more than 800 papers, written over 100 chapters, and is editor, co-editor of 33 books, many of which, I should say, occupy space on my bookshelves of my library. The title of the presentation is, Are Targeted and Immunotherapy Regimens Going to Replace Platinum-Based Regimens and Autologous Stem Cell Transplantation for Salvage in Classic Hodgkin's Lymphoma? Dr. Armitage, thank you for being with us. We look forward to your talk.
Hello, this is Jim Armitage. I am pleased to have the opportunity to speak at the annual Saudi Hematology Conference. And the topic that I have today, that I was given, is targeted and immunotherapy regimens. Are they going to replace platinum-based regimens and autologous transplantation for salvage therapy in classical Hodgkin lymphoma? Now, this is not a trivial topic, actually. And we're going to have to choose specific bits of information to deal with to get it completely addressed in the time we have. So first, I would like to go back and talk just a little bit about autologous transplantation. You remember that Hodgkin lymphoma was almost always a fatal disease until radiotherapy was developed, and then still very few patients were cured by radiotherapy. And it was in the 1970s that MOP, the first effective chemotherapy regimen, was introduced, and that really made a big change in the survival of patients with Hodgkin lymphoma. However, didn't cure everybody, and patients still relapsed. In the 1980s, our team at Nebraska and several other institutions around the world began to try a new idea to see if we could rescue some of those patients with Hodgkin lymphoma who failed upfront chemotherapy. And this concept involved the use of very high-dose chemotherapy, usually a regimen called BEAM, which is carmustine, etoposide, cytarabine, and melphalan, all given intravenously in very high doses that would be expected to cause permanent bone marrow injury. But patients had hematopoietic stem cells stored beforehand and then received the chemotherapy, then got the hematopoietic stem cells reinfused. This reestablished marrow function, and it turned out that we were able to cure some patients with relapsed or refractory classical Hodgkin lymphoma. Interestingly, unlike the situation for most aggressive non-Hodgkin's lymphomas like diffuse large B-cell lymphoma, a few patients with chemotherapy-resistant classical Hodgkin lymphoma were able to be cured with this approach. By the end of the 1980s or the early 1990s, work done here and other places led to replacing bone marrow-derived hematopoietic stem cells for those obtained from the peripheral blood by apheresis. And this became a standard therapy to try to cure patients with Hodgkin lymphoma who were unable to be cured by other approaches. The concept that was being used is this. If you look at these three curves on this slide, or columns on this slide, and this is the level that once the dose intensity represented by the columns, once the dose intensity passes this, then patients will die frequently from marrow toxicity. Patients that would be in this column would die from other organ toxicity. In each case, this is supposed to represent the amount of chemotherapy that would have to be given to cure a patient. And the idea that was being tested was that between the level of dose intensity that kills patients because of marrow toxicity and the dose that would kill a patient because of other organ injury, there might be a window of opportunity. And if we could replace bone marrow function, then patients could be cured uniquely, that cured in a way they otherwise couldn't be. So after there were reports of phase 2 studies, it was appropriate that a phase 3 study was carried out in the early 1990s in the United Kingdom by Dr. Lynch, and they took 40 patients and they were randomly allocated to an auto transplant using the BEAM regimen, or the same drugs, but given at lower doses that could be administered safely without an autologous transplant. And you can see they had 40 patients. Most of these had multiple chemotherapy regimens, and half of them had never achieved a complete remission. So these were very high-risk patients. And here is the result. This is event-free survival, and you can see that around 70% of these people achieved a complete remission, and patients who had the auto transplant had much more durable remissions than those who received the same drugs at standard doses, confirming the idea that this was uniquely able to rescue patients. Now, we've done things a lot better since then. We have better source of hematopoietic stem cells, we're better at supportive care, and we're better at choosing patients likely to benefit from the auto transplant. And this is a series published in the British Journal of Hematology recently from Memorial Sloan Kettering, looking at a fairly large number of patients who underwent auto transplant for relapsed or refractory classical Hodgkin lymphoma. I want you to note that on the left-hand curve, the amount of people, these are event-free survival, you can see that about half of these people had long-term disease-free survival. And the overall survival was roughly comparable, with a few people dying from other things. So it still works, it's a curative therapy. And what we're going to do today is to see if it's always necessary, particularly in light of the new treatments that are becoming available. Before I do that, I want to address another issue that sometimes is forgotten. And that is that there are a few circumstances where the patient doesn't need some new innovative therapy and they don't need an auto transplant. They can be cured more simply with relapsed or primarily refractory classical Hodgkin lymphoma. This isn't very many patients, but it happens sometimes. And I'm going to talk about two situations in which this should be considered. One is that rare patient who has a relatively localized recurrence or area of resistant disease. And this was an abstract from ASH just a few months ago, where a group of hospitals pulled their data and found 22 patients. These were patients 2/3 of the time, they relapsed from a remission, and 1/3 of the time never achieved a remission. There were 3 patients of those 22 who failed, in addition to chemotherapy, radiotherapy, but the recurrence here was out of field. The patients all had relatively localized disease. That is, either one spot or a few spots close together that could be reasonably treated with radiotherapy. And this is the outcome. You can see that relapsed or refractory patients did about the same. Note that this time is in years. And so these patients, about 2/3 of them were continuously free of disease for 5 years after this therapy. It's something that's important to remember. It's way easier to give involved field radiotherapy than it is to do a transplant or to do some of the new treatments we're about to discuss. And it would be unwise to forget that once in a while, not very often, but once in a while, you'll find a patient that can be cured this way. The other treatment was just reported from the German Hodgkin study group, and they took people with early stage Hodgkin lymphoma, favorable early stage, who got ABVD and then relapsed. And some of these patients they treated with BIACOP, as you know, a very intensive standard chemotherapy regimen. and others had the more standard therapy and auto transplant. And what you can see here, and why this paper was published in JCO just recently, is that for these patients who had localized disease, good prognosis patients, but were chemotherapy resistant to ABVD, that is, they relapsed after ABVD, you can see that the auto transplant was not significantly different in either progression-free survival or overall survival from giving the patients Biacop. Now, to be honest, I'm not certain that Biacop might not be more difficult than an auto transplant these days and has at least as high a risk of second malignancies later. But for patients who either couldn't be a candidate for an auto transplant or wouldn't want to pursue it, you can remember that if the patient failed ABVD and they started out with good prognosis disease, then sometimes they can be cured with Biacop. All right, now we're going to talk about these new treatments. And first of all, I want you to stop and remember that all relapsed and refractory patients are not the same. The regimens that they receive, both the number of those and the quality of them, for example, what we just talked about, ABVD and Biacop are different, and the number of treatments they failed can be different. The age of the patient can affect outcome. The extent of the relapse or where they were refractory and whether or not there's bulky disease. Their comorbidities, if they have renal failure, coronary artery disease, chronic lung disease, and so on, diabetes, these can all impact outcome. And whether or not the patients had failed a previous auto transplant or whether they were treated in lieu of an auto transplant with these new regimens. Now, this data is not always available, but we have to take into account the fact that the data we're going to look at is imperfect and we can't know how these variables might affect the outcome with confidence. All right, now here's what I'm going to talk about. I'm going to divide the new treatments up into these categories. These aren't the only new things available, but they're the ones I think are most interesting for us today. One is antibody toxins, and the only one we're going to talk about is Braintexamidone. It's obviously by far the most widely used, but there are some new of these compounds available. And so it alone, there are different immune therapies, but we're going to talk just about PD-1 inhibitors and some data on nivolumab and some data on pembrolizumab, and we're going to talk about their use as a single agent. Then we're going to talk about combinations of these two or those and other things. Then we'll talk about T-cell directed therapies like CAR T-cell and bispecific antibodies. And some of these, and not all of them, will be in patients who failed auto transplant, but they can also be used after an auto transplant. We know that Braintexamidone today is frequently used as an adjuvant to transplant. Well, I'll show you a new approach to that. First of all, Braintexamidone as a single agent has a high response rate in relapse refractory Hodgkin lymphoma that led it to be approved. About a third of the patients achieve a complete remission, so that's impressive. And the biggest toxicity is neuropathy or neutropenia. The neutropenia, under some circumstances, will require growth factor support. Now, note that this drug's been around for a while, and this is in months, and this curve covers about 5 years. And you can see that those patients who achieve a complete remission with Braintexamidone can do well, with a significant proportion of them, somewhere in the range of 2/3 of them, still in complete remission, approaching 5 years. So this is impressive. And in fact, a few patients do appear to be salvageable with relapse refractory Hodgkin lymphoma with just Braintexamidone. Keep in mind, by the way, this is 2/3 of 1/3. So we're down to around 20% of patients, but still, that's impressive. Then what about single agent PD-1 inhibitors? First of all, nivolumab. And this is a recent paper of 243 patients, multi-institutional study. Of these patients, about a quarter had never received Braintexamidone. And you can see with this waterfall plot that the overwhelming majority of the patients had a response. more than 2/3 of them had at least a partial response, and some had a complete remission. A few of those are people who had failed both Braintexamidone and an auto transplant. What was the follow-up? Well, this is the responding patients, and you can see those patients who achieved a complete remission. Now, this is a minority of the patients, but those that did, at 1 year, about 85% were still in complete remission. It's difficult to look at this curve and be confident what the long-term outcome is going to be. Even the partial responders, about half of those were still responding at 1 year. And this is survival. And I want you to note, as is often true for patients treated with PD-1 inhibitors in a number of diseases, the survival was seemingly better than the response rate, with almost all the patients alive at around 2 years. So effective treatment. This is a similar data for pembrolizumab, but these are people who all failed Braintexamidone, and almost all of them an auto transplant. I want you to note that still, this is in weeks now, still at a year, about half the patients hadn't progressed. So it's not terribly different than the other data. And very high proportion continue to survive. Similar with less patients than nivolumab. All right. Well, if you had to choose between them, which is more effective, Braintexamidone or a PD-1 inhibitor, in this case, pembrolizumab, and we're choose this because this is the one that there has been a study to try to address this very question. This is data from a randomized trial, multi-institutional, taking patients who have failed an auto or in some cases an allo transplant for classical Hodgkin lymphoma. And you can see that at 1 year, a higher proportion of them continued without progression if they received pembrolizumab than if they received Braintexamidone. And this was a very significant difference. Once again, you see with Braintexamidone, you have this seemingly flattening of the curve with some patients going on for a long time. And in this case, similar outcome for pembrolizumab, where we have long enough follow-up to compare the two. But if you had to choose one or the other, and this is the only data you had available, it would seemingly be better to choose the pembrolizumab. I'd be cautious about what I just said, though, given the fact that there's longer follow-up for studies with Braintexamidone. Well, here is another situation, and that is using these drugs as consolidation therapy after autologous transplant for high-risk patients with classical Hodgkin lymphoma. I told you before, and I'm sure you all are aware of the fact that studies done primarily led from a group at Memorial Sloan Kettering showed that you take high-risk patients after an auto transplant and give them single-agent Braintexamidone, you improve the chances that they'll be long-term disease-free survivors after the auto transplant. It has toxicity, specifically neurotoxicity, but we know that it cures more patients. Well, these investigators reported 59 patients in this study from recent ASH. About a third were refractory initially. A little less than 2/3 were early relapses, and about 40% had extranodal sites of disease. These and a few other things made up the high risk factors, and 2/3 of these patients had multiple adverse risk factors. The goal was to give 8 cycles of this combination, and the median was 8. In over half the patients, they were able to accomplish this goal. There was 1 treatment-related death out of the 59 patients. And this is the progression-free survival in all the patients. Now, these were high-risk patients undergoing auto transplant. And if you're involved in this, you know that a 3-year progression-free survival and 90% after an auto transplant is very good. So this is really very encouraging. And this is the same data but dividing the patients into who had only one high risk factor and those who had multiple high risk factors. And you can see that they all did very well. Of the patients who only had one of those risk factors, 100% of them continued free of disease according to the actuarial curve at 2.5 years, as opposed to 92% of those who had multiple risk factors. I think this is actually quite exciting data. And if the data holds up with longer follow-up, and perhaps there could be a randomized trial comparing Braintexamidone to the combination or each of the three parts. I think this has the chance to potentially change practice. Now, there are other ways we could do immune therapies. We could use targeted T cells. That is, do CAR T cell therapy. Now, it's been very hard to do in Hodgkin lymphoma because you had to develop the T cells for the right target. But in this study, also published in JCO just recently, they chose CAR T cells targeted at CD30. This is the first 41 patients treated. 10 of the patients had cytokine release syndrome, a relatively small number, and all grade 1. So this was a very well tolerated approach, and none of the patients had significant neurotoxicity. 62% of the patients responded, and half had a complete remission after the CAR T cell therapy. And this shows you the actuarial outcome. The overall survival is excellent, with 90% of the patients continue alive out to 3 years. But the progression-free survival was less encouraging, with the 1-year progression-free survival of a little better than a third of the patients. This is the first attempt at CAR T cell therapy. There's every reason to believe it'll get better, but at the moment, it doesn't look probably as encouraging as some of the other approaches we talked about. And finally, the other T cell therapy I want to mention are these bispecific T cell engaging antibodies. These are being used in increasing numbers of diseases. And instead of making CAR T cells outside the body, what you do is make this bispecific antibody that takes the T cell, attaches to it, and carries it to the target. This treatment, if it can be worked out, and if there is no new unexpected toxicity, this has the opportunity to potentially put CAR T cell therapy out of business because it would be cheaper, it's available to everybody. It's an interesting approach. And the data in some aggressive B-cell lymphomas is quite exciting. This is the first report I know of in Hodgkin lymphoma, and you can see that the results were less spectacular, where by 6 months, 3/4 of the patients had progressed, although there were a couple of long survivors. So once again, there's lots of questions here that need to be sorted out, and this is something to keep an eye on, but at the moment, not likely to be replacing autotransplants. So these are my conclusions. First, that it is certain that some patients with classical Hodgkin lymphoma who fail curative treatment can be cured as second-line treatment or even later. As I said, in this disease, some patients with much more advanced disease can still be cured with autotransplants. So we know that the possibility for cure exists. I would say my conclusion to the question that I was asked when I was asked to give this talk, my conclusion is that for most patients with chemotherapy-sensitive relapsed classical Hodgkin lymphoma, autotransplant remains the best choice. It has a longer follow-up. We know it can cure patients. A third thing would be a few patients with minimal disease that can be cured with radiotherapy or more intensive chemotherapy and don't need a transplant. Don't forget that. But finally, the most exciting information is this. I think targeted therapies are immunotherapies. First of all, might be the best way to achieve minimal residual disease to allow a patient to get to an autotransplant. in several circumstances. That is, cisplatin-contained regimens might be more dangerous and not more effective, then it's going to turn out what we can accomplish with drugs like Braintexamidone or PD-1 blocking antibodies. Secondly, the data I showed you suggests that some patients can be long survivors with either Braintexamidone, probably nivolumab or pembrolizumab, and probably with the combination of the two. And if we could identify which patients might be cured with that approach, it might replace autotransplant for those patients as the best choice. And finally, the data I showed you about combinations of Braintexamidone and a PD-1 antibody, the study used pembrolizumab, suggests that the results are so good as a consolidating therapy after autotransplant that might replace Braintexamidone consolidation as standard therapy as an adjuvant treatment after autotransplant. I want to thank you for your attention. You can see that the companies with which I have a relationship, none of which would particularly apply here. And I want to thank you for listening. I'll be happy to answer questions or comments.